Today we are covering gastrointestinal bleeding, a critical topic the NCLEX will test through prioritization and assessment questions. The first step is determining if the bleed is upper or lower GI, as this dictates immediate actions. An upper GI bleed, originating above the ligament of Treitz, often presents with hematemesis, which is vomiting blood. If it's bright red, it's an active, dangerous bleed. If it looks like coffee grounds, the blood has been sitting in the stomach and has been partially digested by acid. Another key sign of an upper GI bleed is melena, which are black, tarry, foul-smelling stools from digested blood. In contrast, a lower GI bleed typically presents with hematochezia, which is the passage of bright red blood from the rectum. The NCLEX loves to test this differentiation. For example, a question might describe a patient with a history of chronic NSAID use presenting with black, tarry stools. You must immediately recognize this as a probable upper GI bleed from peptic ulcer disease. Now, let's consider a classic NCLEX-style priority question. You have a patient admitted with cirrhosis who suddenly vomits a large amount of bright red blood. His blood pressure is 88/50, and his heart rate is 130. What is the nurse's first action? The options might be to administer a beta blocker, insert an NG tube, check the latest hemoglobin level, or ensure 2 large-bore IVs are in place. The correct answer is establishing IV access. This patient is in hypovolemic shock from a likely esophageal variceal rupture. The immediate priority is circulation and fluid resuscitation. Checking labs is important, but it doesn't fix the immediate problem of shock. This brings us to a common exam tract. In an acute, massive hemorrhage, the initial hemoglobin and hematocrit may be normal. Why? Because the patient is losing whole blood, so the concentration of red blood cells in the plasma hasn't changed yet. It takes time for the body to compensate and for IV fluids to dilute the blood, revealing the true extent of the loss. The NCLEX might present a patient with clear signs of a bleed, but a normal H&H to trick you into delaying intervention. Always trust your clinical assessment over an initial lab value. For a mental shortcut, remember the mnemonic bleed for your assessment priorities. B is for blood pressure and heart rate, assessing for tachycardia and hypotension. L is for level of consciousness, as confusion or lethargy can indicate poor cerebral perfusion. The first E is for establish IV access, always with large-bore catheters, typically 18 gauge or larger, in anticipation of blood transfusions. The second E is to evaluate labs, but remember the timing issue we discussed. Also anticipate orders for a type and cross-match. Finally, D is for determine the characteristics of the stool or emesis to help locate the bleed. Nursing management also involves preparing for interventions. For an upper GI bleed, this usually means an urgent endoscopy. Your role is to maintain NPO status, ensure consent is signed, and monitor vital signs continuously. You may administer proton pump inhibitors like pantoprazole intravenously to decrease stomach acid. For a variceal bleed, you'd anticipate an order for octreotide, which reduces splanchnic blood flow and portal pressure. When administering blood products, you must follow protocol exactly, including verifying the patient and blood product with another nurse and staying with the patient for the first 15 minutes to monitor for a transfusion reaction. Your ultimate goal on the exam is to demonstrate you can keep the patient safe by recognizing signs of hemodynamic instability and acting with urgency.